organizers of the plan. Also, thank you for preponing my talk. I think it's a fair replacement, Nihal Thomas for Reuben Thomas. Though, of course, the talk is going to sound a bit different. So, in this context, I'm an endocrinologist, and I do appear I'm an absolute fish out of water and may find it very difficult to breathe in this audience. So, our work has been in relationship to the physiology and a little bit about the genetics also of this particular condition. And I'm going to allude to, there are various things that we can actually look at together when we come down to the physiology, and which may have important connotations towards the future of treatment of diabetes in this condition. So this is what I'm going to be talking about, a little bit of an introduction, a bit about hypoglycemia, the autonomic dysfunction and the glucagon axis, and also the incretins, which of course you hear a lot more in terms of the excessive use of all these medications which endocrinologists are using to try and make people as skinny as possible, energy expenditure and insulin resistance, and a little bit about the other differential diagnosis for hypoplastic pancreas. So this is what a lot of you guys see or hope not to see at the end of everything over a period of time. But the kind of patients which come to me, and this is the problem with a referral bias, are people who are lean and who have diabetes. And about 60% of them don't have any abdominal pain. So that's how it is. And now, of course, with me in Vellore campus and Ranipat campus, the referral issues have become even more of a problem. So that's the kind of diabetes we have. And let me tell you, the kind of people we see are lean people with mild abdominal pain or no abdominal pain, a bit of steatorrhea in some situations, clinically particularly, and even the beta cell function can be highly variable. So how do we assess them? We measure a C-peptide. The three tests which I tell every general practitioner do when they see someone who has a BMI less than 21 and has diabetes: check a fasting C-peptide, do a GAD antibody to rule out type 1, because they don't have to have ketoacidosis, and third is do an imaging of the abdomen. And you'll be surprised, one of the most important things which is missed out is pancreatic disease, which is otherwise largely asymptomatic, just being lean diabetic. It's a huge number. So this little review which looked at this condition, and which again tells you about the essential aspects of this disease, and you know this map, which is why it is in largely the tropical parts of the world, is a C-peptide deficient disease. But a lot of them in the initial phase, about 40% do respond to oral anti-diabetic agents. I'm talking about adults with this young onset form of diabetes. The C-peptides per se, when you measure them, are not as low as that of type 1 diabetes. So if you draw a graph, you'll find the C-peptides in type 1 diabetes absolutely flat in about 2 years' time. In pancreatic diabetes, the C-peptides or the beta cell function will actually be sufficient for the first 2 years, and it may take as much as 5 years to dip down low. And if you use ultra-sensitive C-peptide measurements with the new assays, they may not be all that low as what we see in type 1 diabetes. And that may be actually one of the reasons why they don't get ketoacidosis, despite a number of other reasons why people talk about why they don't get ketoacidosis, and it really is a very intriguing situation over there. So this was a study which was done in the STPGI some years back, and we helped them out with the genetics. And once again, this is a referral bias to an endocrinologist, telling you that in lean young people, that almost 15% of patients had fibrocalcic pancreatic diabetes, and abdominal symptoms were present only in about 30% of this particular series at that point of time. This is about 12 to 13 years back. So one of the other problems which we face in patients when we treat with fibrocalcic pancreatic diabetes with insulin is hypoglycemia. Now when we treat patients with type 1 diabetes, the standard of care to prevent diabetic ketoacidosis and also to prevent, to ensure good control and this lack of brittle control, is to give insulin 4 times a day with basal bolus insulin, short-acting thrice a day and long-acting at bedtime. But in patients who have fibrocalcic pancreatic diabetes, we can actually get away quite well with twice daily insulin. Now, you must look at the gastroenterologists who may not find a slot to refer patients to us, and they can give an affirmative nod to me and say, do you give twice daily insulin to your patients and get away with it? Or are you not bothered about the HbA1c at the same time? But you can. The fact is you can. But then the other problem that you face in this situation is you do get a lot of hypoglycemia. I won't allude to the fact that, in fact, with Sudipta, some years back, we did publish a paper on autonomic dysfunction in pancreatic diabetes, and we found that almost 60% have autonomic dysfunction. And this may be due to a combination of both nutritional deficiency as well as the fact that their control had been very poor and they came to us really late. Now, one of the other things which we do in all our patients who have young onset diabetes to understand the pathogenesis, you remember that the fact is that, okay, fine, you've taken a certain amount of food, you do a certain amount of exercise, but the mitochondrial function can be highly variable from one person to the other. For example, someone like me may have to exercise 20 kilometers a day to keep my body weight the way it is. But someone like Ruben does absolutely nothing, sitting in the chair that he is, can actually maintain his body weight the way it is without doing any physical activity. Professor Ruben, I hope you're okay. Thank you. Now, energy expenditure is something which we measure to look at how, and it's actually one of those aspects when you talk about obese individuals and lean individuals. And we use this device called an indirect calorimetry we have done it in a lot of patients across different, right from weightlifters to patients with type 1 diabetes, ultra lean malnutrition related diabetes, and even low birth weight people to see what's happening. Now, the intriguing thing that we found over here, that with good control, with an adequate intake of food, there was still a very high disproportionate energy expenditure in these patients. And we thought we were looking at something actually wrong over here. It's published in the Journal of Diabetes a few years back. And sometimes you discover things by accident, and then you can go backwards and see what was happening. Now, the mitochondria are activated by glucagon. So we know that insulin is a very anabolic hormone, and it is not only important for taking up glucose into the periphery, but it is also very important for taking up amino acids as building blocks. And glucagon is quite the opposite. It has a lot of other paracrine effects within the pancreas as well. So glucagon, intriguingly, is increased, turns on the mitochondria and makes you burn more energy. And that is the reason why we found this, but we found this a few years later. We were actually very puzzled, and we wondered that we had made some mistakes in doing this experiment. So this was done a few years later to assess hypoglycemia unawareness. And quite naturally, those with early disease had less hypoglycemia. And when we did mixed meal challenge tests, we found that there were elevated glucagon levels in the initial phase of the disease. So how should a patient who has a very atrophic pancreas and destroyed beta cells, but probably having destroyed alpha cells as well, how can the glucagon levels be high, right? That amount of physiology, I think we all understand. How can the glucagon levels be high? Indeed, so we did this very comprehensive study looking at hypoglycemia unawareness. We did autonomic function tests, mixed meal challenge tests, and looked at the curves in terms of insulin secretion, C-peptides, and glucagon measurements in all of them. And we also intensively measured their glucose control. And what we found over here, particularly in the early disease, yes, the C-peptide levels were much lower in those who had hypoglycemia unawareness. And those who were hypoglycemia aware, the glucagon levels were actually elevated. They were high. They were protecting the patients against hypoglycemia. And when we measured these against controls, we found that these patients actually had protection against hypoglycemia, number one, and the controls had lower glucagon levels. Now this is incredible, amazing, right? So you can see over here correlation between the hypoglycemia index is less, is strong correlation with the glucagon measurements per se. So this is what we found. Now I'll come back to later why this happened, and once again we were puzzled. Why are the glucagon levels in the first place high? Okay, we know that energy expenditure is increased because of the glucagon, but why is the glucagon levels high? Where is it coming from? The next experiment we actually did was on patients with pancreatic disease, and we looked at the bone health, and we found that a significant number of them actually had osteoporosis. So there is room for early treatment with bisphosphonates in these patients, and we found it was not related to the vitamin D deficiency. It was more related to fat malabsorption in these individuals. Okay, So I'll come next. This is basically my summary. Hypergluceminemia is seen in these individuals. Hypoglycemia unawareness is very common in these individuals. We need to be careful when we treat these people following 3 meals and 3 snacks in these individuals. I had this secretary who used to type out very often, and when she was new, she used to type out 3 meals and 3 snakes, and that's even if you're a vegetarian. That was actually quite inappropriate. So hypoglycemia is associated with improved awareness in these patients, but that doesn't last for very long. So the next step is we realize that there's a common proglucagon genome, and this proglucagon genome drives the production of glucagon. It also drives the production of the other hormones called the incretins. And just reminding you that the incretins are produced by the L cells in the intestine, and GIP, another incretin, is produced by the K cells of the intestine. So we tried to look at the pancreas very comprehensively, the fibrocalcic pancreatic disease, looking at insulin sensitivity, insulin resistance, and the body composition of all these individuals. So we asked these questions. Why does hypoglycemia occur in these alpha cell deficient atrophic calcific pancreatitis? Shouldn't it be insufficient? So these are our patients. We compared patients with fibrocalcic pancreatic diabetes, type 1, and normal individuals over here. And we did not take patients who had a very long duration of diabetes, because we know that their beta cells might be depleted over a period of time. Now these are called pancreatic clamp studies. They are very intensive studies. We need to have good glucose control, and then we clamp the glucose levels. We keep the glucose levels at 90 milligrams deciliter for a period of almost 6 hours. It's a very challenging thing when you infuse glucose and insulin at the same time. And they'll tell you about insulin sensitivity. So if the patients are insulin resistant, you need to give more insulin to maintain the glucose at 90 milligram per deciliter. Simple as that, but it's a very arduous process, and our nurses are trained to do that. We also did energy expenditure studies, and we measured the micro quantities of fat in the liver and the muscle. This is the clamp study that we did. And what we found, they were C-peptide deficient, so they were deficient in beta cell function. Pancreatic polypeptides were low, and the GIP levels from the K cells were also low. Now what we found intriguing over here is that the glucagon levels indeed, once again replicated in the experiment, were elevated, and it rose parallel to that of the GLP-1 and the auxin-to-modulin levels, which both come from the L cells. Now, animal studies have actually shown, if you take out the pancreas of a dog, that the L cells in the intestine start producing incretins and glucagon. So the glucagon is probably coming from the intestine. And this curve over here also shows you that the glucagon levels rise parallel to the GLP-1, inferring that it's the same thing. Now I must ask my gastroenterology colleagues, would it be ethical to go and do an intestinal biopsy in one of these guys? I don't think my ethics committee would allow me to see whether the L cells actually immunostaining with glucagon at the same time in these patients. You could. We should do it. Thank you. All right. So let me summarize. This is the physiology of this condition. High glucagon secretion, energy expenditure, worse glycemic control. High GLP-1 secretion doesn't seem to help in improving the glycemic control. Suppressed C-peptide, suppressed pancreatic peptide, low hepatic resistance and low peripheral resistance. So they don't have much of an insulin resistant state. This is what we found in these patients. Just a little bit about this, and I think I've overshot my time. Pardon me. Little bit about the genetic work which we have done. We have done it right across the lean diabetes spectrum, from Wolfram's to malnutrition modulated diabetes to other conditions as well. And of course, this is lovely publication by Sudipta and also the Indian Institute of Science group, which came out. This is our work, which we found that there was a significant association between this pink positivity and the presence of a malabsorption in these individuals. The fat malabsorption was much worse. We have another condition where you can get lean people which can also have fat malabsorption in some patients. This MODY5 or maturity onset diabetes can come from a spectrum of requiring only oral anti-diabetic agents to insulinopenia on the other spectrum. And these patients can have other morphological disorders like uterine anomalies and a shrunken pancreas. And these people can have either gross insulin deficiency with ketoacidosis, or they can come like a pancreatic diabetes without ketoacidosis and malabsorption. So these are the differentials that we should look for. And here, of course, is the pediatric pulmonology experience, wherein they have shown patients who have fatty pancreas with steatoria, and a number of patients of those who came with pulmonary presentations incidentally had cystic fibrosis, and going further had pancreatic. So this is something which we should increasingly look for, which I'm sure you are all looking for now with greater ardor as well. Here was another lady whom I looked after for many years. I thought she had acute pancreatitis. It became chronic, became fibrocalcic pancreatic diabetes. That's what I thought she had. Then her daughter came with muscle weakness and lactic acidosis and headaches, and she had a neurological syndrome with muscle weakness. So this patient actually had a mitochondrial disorder with the heteroplasmy being greater in the child and lower in the adult over here as a presentation. So we have this particular panel which we now do for all our patients with pancreatitis, both acute and chronic, and those who have lean diabetes. When we do even the slightest suspicion of a pancreas which may be even mildly atrophic on a CT, we actually do this panel as a routine basis over there. And these are our findings of the spectrum that we have found in our patients as well. So when we see a lean patient, this is our differential diagnosis. I keep this as number 2 on the list. Number 1 is, of course, type 1 or slowly evolving immune-mediated diabetes. That's number 2, pancreatic disease. Genetic disorders, only some, like MODY5. Rarer conditions like Wolfram's and lipodystrophy. And then type 5 diabetes, which is the malnutrition modulated diabetes, which we deal with in addition. So I'm just covering what I've told you about. We think about this particular condition, we should understand the physiology intricately, may have a lot of implications on the long-term basis in terms of our therapy as well. And I'd like to thank our funding agencies for all this research and all the wonderful people who we have worked with, gastroenterologists in particular, and many of the others, radiology, etc., who have helped us over a long-term basis. Thank you so much for your patient listening.